Hey, pediatric nursing fam, let's talk tiny humans.
Welcome.
Welcome to the deep dive. Today, we're taking a plunge into the truly incredible world of newborns and infants. Those first few months, wow, there's such a whirlwind of development.
They really are.
And we've got a stack of source material just packed with the need-to-know insights.
That's right. We're pulling from a really in-depth chapter focusing entirely on this foundational period. It covers, everything, from those miraculous first breaths to the lightning-fast developmental leaps and, crucially, the essential nursing care that kind of wraps around it all.
Our mission for this deep dive is pretty simple. Shortcut you right to the most crucial knowledge from these sources.
Get you the key stuff.
Exactly, giving you a solid grasp of what it means to care for our tiniest patients. Let's dive in.
Let's do it.
Okay, let's unpack what happens the literal second these little humans enter the world. That transition from floating inside to breathing air is just mind-blowing.
It really is. What's fascinating here, I think, is just how complex that shift is. For every single body system. The sources really highlight this. They touch on viability, the chance of survival.
Right.
And show how it shoots up dramatically after 22 weeks gestation.
Right.
And looks a lot like a full-term baby's chances after 34 weeks. It's a rapid acceleration.
And our first peek into how well they're making that massive adjustment, that's the APGAR score.
Absolutely. The APGAR. Developed by Dr. Virginia Apgar way back in 1952.
A classic.
It's not just a number, right? It's a quick evaluation of how they're adapting to, the stress of birth.
Okay.
It looks at 5 core things: their breathing effort, heart rate, muscle tone, color, and reflex irritability, how they react.
Each gets a score, 0 to 2. Adds up to 10 total.
Yeah.
So think of 7 to 10 as doing great, just needs routine care.
Good to go.
A score of 3 to 6 means they probably need some help, maybe a little stimulation or oxygen.
Right, moderate depression.
And below 3 tells us they need active resuscitation, like now.
Yeah, severely depressed. And the timing of that score is key.
How so?
That 1-minute score tells us immediately if they need help right now.
Okay.
The 5-minute score tells us how well they're responding to anything we did and gives us a picture of their overall status. It can even hint at potential long-term outcomes if that score stays low.
So, if they're pink and crying hard, that's top marks.
Exactly. A 2 for color and respiratory effort.
But no heart rate or totally floppy.
That's a 0. It's this incredibly powerful, quick snapshot in those critical first moments.
Right. So right after assessing them, there's also that essential prophylactic care we provide.
Exactly. Like the vitamin K shot, phytonadione K1.
Why do they need that one?
Newborns essentially have sterile guts when they're born.
Okay.
They can't make their own vitamin K yet, which is vital for blood clotting.
All right.
So giving 0.5 to 1 milligram intramuscularly, usually in the vastus lateralis muscle, that big thigh muscle, within the first hour prevents a type of bleeding disorder. Can be quite serious.
Got it. And the erythromycin eye ointment.
Yeah, that's all about preventing serious eye infections. Things like gonorrhea and chlamydia.
Which could potentially blind them if untreated.
Absolutely. You apply just a small ribbon along the lower eyelid, inner to outer.
Okay.
And the sources note it's important to try and delay this for that first hour, if possible.
Why is that?
To allow for that uninterrupted skin-to-skin time.
Bonding.
And the start of bonding and breastfeeding. That golden hour.
Makes sense. And we can't forget the hepatitis B immunization.
Right. Prevents hepatitis B infection. The timing depends on the mother's status.
Okay.
If she's positive or unknown, baby gets the vaccine and hepatitis B immune globulin within 12 hours.
Alpha.
Yep. If mom's negative, just the vaccine within 24 hours.
Same spot. Vastus lateralis.
Same spot. And it's often mandated by state law, really. It's the start of their immunization schedule.
So beyond these initial meds, early care includes simple things too, like cord care, potentially circumcision care, that first bath.
Right.
And really making it family-centered. The sources emphasize things like dignity, respect.
Yeah, information sharing.
Involving the family, collaborating.
And a huge part of providing that care is knowing the maternal history.
Oh, definitely.
Like prenatal care details, any infections, screenings done during pregnancy.
Labor issues.
Labor and delivery issues, yeah. And critically, any history of substance use.
Perinatal substance abuse is a major focus in the sources, and it's just heartbreaking.
It really is.
Neonatal abstinence syndrome, ANS, from drug withdrawal. it's unfortunately increasing.
Yeah.
That statistic, a baby born suffering from opioid withdrawal every 15 minutes, is incredibly sobering.
It is.
Yeah.
And NAS isn't just about opioids, though they're a major cause. The symptoms are varied.
Affects multiple systems.
Yeah. Extreme irritability, that really high-pitched cry, increased muscle tone, even seizures from the CNS irritability.
Wow.
You see autonomic issues, too, like sweating, sneezing, GI problems, vomiting, diarrhea, respiratory symptoms.
And the sources also link nicotine and alcohol exposure in utero to a 12-fold increased risk for SIDs compared to unexposed babies.
12 times. It's significant.
So how do we figure out what they were exposed to?
Testing can use meconium, hair, cord blood, or urine.
Okay.
And to measure how severe the withdrawal is, the Finnegan Neonatal Abstinence Scoring Tool is widely used.
The Finnegan score.
Yeah. It looks at symptoms across CNS, GI, metabolic, vasomotor, respiratory areas.
And you score them often?
Usually every 3 hours, typically before feedings, to track the pattern.
So what are the interventions?
Starts non-pharmacologically. Swaddling, comforting, focusing on feeding, keeping them calm.
Right.
If those scores stay high, usually consistently above 8 on the Finnegan,
Then meds.
then pharmacological treatment. Usually morphine sulfate or methadone is initiated,
Okay.
with doses carefully weaned as the baby improves. The AAP even recommends opioid replacement therapy if those non-pharm approaches just aren't enough.
It's just amazing to think about how much physiological chaos is happening inside these tiny bodies as they adjust.
So much going on.
Let's look at a few key systems and the remarkable transitions they make. This is where it gets really interesting.
Yeah, the transition from like fluid-filled lungs and placental circulation to air breathing and independent circulation.
Yeah.
It's truly monumental.
Absolutely.
Understanding these shifts is fundamental, helps you recognize what's normal and what's, well, not.
Right. That first breath, huge moment. What triggers it?
It's a combo of things, really. Internal chemical changes happen from the mild hypoxia and CO2 buildup during delivery.
Okay. Yeah.
And then there are external stimuli, the cold air hitting them,
Yeah.
the sensory input from being handled, and the mechanical squeeze from passing through the birth canal.
Right.
And once that umbilical cord is clamped, boom, no more oxygen from mom.
They have to breathe.
I have to.
Yeah.
And surfactant, that soapy stuff in the lungs, produced around 34 weeks. So crucial. It keeps the tiny air sacs, the alveoli, from collapsing, drastically reduces the effort needed to breathe.
And if there isn't enough surfactant, especially in preemies, you see respiratory distress syndrome, RDS.
Right. Stiff lungs, chronic issues, potentially.
And retained fluid.
Can cause transient tachypnea, TTN, just fast breathing that usually clears up on its own.
Okay.
And if those blood vessels in the lungs don't relax properly like they should after birth, it leads to persistent pulmonary hypertension of the newborn, PPHN.
So assessing their breathing involves watching for chest wall symmetry and looking at the pattern. Normally, it's a bit irregular, shallow, sporadic.
Belly breathers.
They're belly breathers, right? We count the rate for a full minute. Should be 30-60 initially.
Right.
And acrocyanosis, blue hands and feet.
Normal for the first day or two, usually.
But bluish lips or trunk, circumoral cyanosis or widespread blueness is not normal.
Definitely not. Needs immediate attention. Always check mucous membranes in darker skinned babies.
And the signs that something is really wrong, those red flags are critical.
Yeah, things like any blue color beyond just hands, feet after that initial period.
Okay.
Pauses in breathing longer than 15-20 seconds, what we call apnea.
Gasping.
Gasping, nostrils flaring, excessive mucus, rapid breathing over 60 when they're calm.
Tachypnea.
Right. A fast heart rate over 160 when calm, uneven chest movement. Grunting sounds with breathing.
Grunting is a big one.
Definitely. Or retractions, those indents they make in the chest or neck as they struggle to pull air in. Suprasternal, supraclavicular, all those spots.
Okay, circulatory system does a similar flip-flop.
Right, totally. Cord clamped, lungs fill with air. Blood flow patterns change drastically. Decreased prostaglandin signal those fetal bypass route, the ductus arteriosus, foramen ovale, ductus venosus to start closing up.
Fascinating. And we check the umbilical cord.
Yep. Usually 2 arteries, 1 vein, AVA.
2 arteries, 1 vein.
Finding only 2 vessels, like 1 artery, 1 vein, can sometimes be linked to kidney issues.
Yeah.
So you note that.
Good to know. Their heart rate is much faster than ours.
Oh, yeah. Typically 120, 160 beats per minute at rest. Again, count for a full minute.
Okay.
And checking capillary refill, how quickly color returns after gently pressing a nail bed or skin.
Should be fast.
Brisk. Yeah. Less than 3 seconds. More than 4 is abnormal.
And if those fetal structures don't close properly?
That's a common cause of congenital heart defects.
Okay. And speaking of the cord, delayed cord clamping is now recommended practice.
It is. ACOG advises waiting 30-60 seconds or until the pulsation stops, which can be up to 90 seconds sometimes.
What are the benefits?
The sources highlight quite a few. Increased iron and hemoglobin, lower risk of anemia, decreased risk of intraventricular hemorrhage, bleeding in the brain,
Wow.
and increased transfer of valuable stem cells to the baby.
Does it affect jaundice?
Interestingly, no. The evidence shows it does not impact bilirubin levels.
Okay.
Just note, though, this isn't an option if parents are banking cord blood, because that requires clamping right away to collect the blood before it flows back to the baby.
Gotcha. Okay, another big adjustment. Temperature control. Babies are little heat loss machines.
They really struggle. They have a large surface area compared to their body mass, and their metabolic rate is high.
So our goal is
to keep them in a neutral thermal environment. That's the temperature where they use the least amount of energy and oxygen just to stay warm.
prevents problems.
Exactly. Prevents them from getting acidotic or depleting their special brown fat stores.
And they can't shiver like we do.
Nope. Newborns do not shiver. They rely on tightening peripheral blood vessels.
Vasoconstriction.
Right. And crucially, burning that brown fat. Chemical thermogenesis?
Tell me more about brown fat.
Yeah, brown adipose tissue, BAT. It's specialized tissue that burns really quickly just to make heat.
Okay.
But when they get cold, they burn it too fast.
What happens then?
This rapid use depletes their stores, uses up glucose, increases their oxygen demand, can lead to acidosis, makes jaundice worse, and hinders weight gain.
It's a cascade. That sounds serious. What are the signs of cold stress, and why is it so risky?
Cold stress is when their temperature drops and they start the cycle. Increased O2 and glucose use, burning BAT.
Right.
Depleting glycogen stores, which can decrease surfactant production.
Oh, leading to respiratory issues.
Exactly. Worsening RDS and potentially metabolic acidosis. The signs aren't shivering, but things like jitteriness.
Jitteriness, like low blood sugar.
Exactly. It can look similar. Also, tachypnea, grunting, hypoglycemia itself, poor muscle tone, pallor, lethargy, and a weak suck.
So it significantly increases their risk of serious problems.
Major morbidity and even mortality risk. It's critical to prevent.
So nursing interventions to minimize heat loss are crucial.
Absolutely. We use double-walled isolates or covers to prevent heat loss by radiation to cold surfaces.
Like windows?
Yeah, or cold walls. Warm surfaces for exams. Removing wet lesions promptly prevents conduction loss.
Makes sense.
Dressing them in layers and using a cap minimizes convection and radiation losses.
What about radiant warmers?
Those are great for naked infants needing procedures or assessment. They use a servo control probe on the baby's skin to regulate the heat.
Okay.
But you have to monitor closely because the external warmth can sometimes mask a fever if they're developing sepsis.
Good point.
And never put artificial heating devices like hot water bottles directly on their skin. Huge burn risk.
So constant monitoring.
Temp, heart rate, respiratory rate, glucose, and remember gestational age is a big factor. Preemies struggle the most with temp regulation.
The sources also brought up interesting research about delaying the first bath.
Yeah, Warren et al., 2020, suggested delaying beyond 24 hours actually helps increase breastfeeding rates and decreases hypothermia and hypoglycemia.
Challenges traditional practice.
It does. Highlights the importance of looking at current evidence.
And speaking of warmth and care, kangaroo care, skin to skin, is huge.
It's incredibly beneficial. It's been a practice in some cultures for decades, now widely recognized. The AHON brief mentioned highlights its value.
The benefits for the baby are amazing. Stable heart rate, breathing.
Better oxygen levels, improved weight gain, less crying.
Better breastfeeding success.
Yep, and potentially earlier discharge.
And for mom.
Can boost milk supply, increase her confidence, enhance that vital bonding.
Important for safety, though.
Yes, especially in the first couple of hours after birth, health personnel should be present during skin-to-skin, particularly after C-sections or difficult deliveries. Recommended for all stable-term infants.
Okay, let's shift to the metabolic system, particularly glucose. Primary fuel for the brain.
Right. They store it as glycogen late in pregnancy, and they burn through it fast, coping with birth stress, breathing, heat production, activity.
Glucose levels dip after the cord is clamped.
Yeah, that decrease triggers hormonal changes, increases in epinephrine, norepinephrine, glucagon, decrease in insulin to try and stabilize it.
But hypoglycemia is common.
Below 40 mg/dL, it's the most frequent metabolic issue in the first 48 hours.
Why does it happen?
Can be increased demand, like from cold stress, hypoxia, or infection.
Using it up too fast.
Exactly. Or they might have decreased stores prematurity, SGA, IUGR babies, or errors of metabolism.
Sometimes decreased supply.
Yeah, like in post-term babies where the placenta might have been deteriorating, or if mom received terbutaline.
And crucially, infants of diabetic mothers are at high risk.
Very high risk. Their pancreas got used to producing extra insulin in utero to handle mom's high glucose.
So after birth.
That high glucose supply is gone, but their pancreas is still pumping out tons of insulin, dropping their blood sugar low.
Can happen in LGA babies too?
Yes, large for gestational age, or conditions like Beckwith-Wiedemann syndrome. High insulin is the issue.
So monitoring is essential.
Especially for those at risk. While normal levels vary a bit, a heel stick screening glucose below 40 needs confirmation with a lab draw stat.
What are the goals?
The Pediatric Endocrine Society recommends targets above 50 in the first 48 hours and above 60 after that.
And treatment.
Often simple. Early frequent feeding is key. If levels are very low or feeding isn't enough, IV glucose. And critically, maintain that neutral thermal environment.
Prevent cold stress from burning glucose.
Exactly.
And this leads perfectly into newborn screening.
Yeah.
A massive public health success story.
Absolutely. Millions screened, thousands diagnosed with conditions they might not show symptoms for right away.
State requirements vary, but it's usually a capillary blood sample on filter paper.
Yep, collected 24-48 hours after birth, sometimes a second screen later, depending on the state.
Catches things like PKU.
Phenylketonuria, yeah. An enzyme deficiency means they can't process phenylalanine, leads to severe cognitive impairment if not caught and managed with a special diet.
And congenital hypothyroidism.
Underactive thyroid. Also causes severe impairment if lifelong hormone replacement isn't started quickly, screened for everywhere because treatment is so effective.
Others include
Congenital adrenal hyperplasia, CAH, affects hormone production, sexual development. Galactosemia, can't process milk, sugar, galactose. Maple syrup urine disease, rare metabolic disorder. Krabs disease, devastating neurological condition. Sickle cell disease.
blood disorder, right?
Yeah, causing pain, organ damage, more common in certain ethnic backgrounds. And cystic fibrosis, affecting lungs and digestion.
The power is catching these before symptoms appear.
Exactly. Allows for early intervention, makes a huge difference.
The hepatic system, the liver, also immature. Vital for carbs, iron, clotting factors, bilirubin.
Right. Iron stores are built late in pregnancy. Breastfed babies usually have enough for 4 months.
They need a supplement.
Liquid supplement, 1 milligil a day until they start iron-fortified solids around 6 months. Formula-fed babies need iron-fortified formula from the start. Everyone needs iron sources after 6 months.
And clotting is linked back to vitamin K.
Yep. Lack of gut flora means they can't make their own initially, increasing bleeding risk. Underscores the importance of that shot.
Which brings us back to bilirubin and jaundice, probably the most visible issue.
Definitely. Bilirubin is a breakdown product of red blood cells. The liver has to process it or conjugate it.
Make it water-soluble.
Exactly. So the body can excrete it in urine and stool if it builds up, especially the unconjugated type.
Deposits in the brain.
Yeah, it can cause kernicterus, brain damage, really serious.
The sources list so many risk factors for high bilirubin.
Oh, yeah. Rh incompatibility, mom's antibodies attacking baby cells, monitored with Coombs test, prematurity, delayed feeding.
Delays meconium passage.
Right, gets rid of bilirubin, bruising from birth trauma, liver immaturity, all newborns have this to some degree, stress like cold or low oxygen.
Maternal oxytocin use.
Yep. Certain ethnicities, East Asian, American Indian, Mediterranean, having a sibling with bad jaundice, and even breastfeeding itself can be a factor.
The monitoring is key, looking at skin color.
Pressing gently over bony areas like the nose or sternum helps, but it's not always accurate, especially in darker skin.
So levels are better.
Definitely. Screening involves getting a bilirubin level, usually heel stick, and plotting it on a nomogram based on age and hours to assess risk.
TCB monitors.
Transcutaneous bilirubinometers. Good for screening non-invasively up to a certain level, like 15 mg/dL maybe. High results always need blood confirmation.
Important to distinguish types of jaundice. Physiological.
Most common. Happens after the first 24 hours. Affects most babies. Peaks around day 3 to Sunan. Usually benign. Stays below concerning levels.
Pathological is the worry.
Right. Appears within the first 24 hours, usually due to a more serious issue causing excessive red blood cell breakdown, incompatibilities, infection, metabolic disorders. Levels rise faster or go higher.
Needs intervention sooner.
Definitely. Like phototherapy, preemies have lower thresholds for treatment, too.
And the sources differentiate breastfeeding jaundice from breast milk jaundice.
Yeah. Breastfeeding jaundice is early onset, often linked to insufficient milk intake, dehydration, delayed meconium. Breast milk jaundice is late onset, peaks around 2 weeks, related to something in the breast milk composition itself.
Nursing interventions focus on monitoring, supporting feeding.
Early and frequent feeding is crucial for getting bilirubin out in the stool, supporting moms with lactation help.
Watching for signs of worsening jaundice.
Yeah, like lethargy, poor feeding, or signs of potential brain involvement, like a high-pitched cry or arching.
Treatment for significant jaundice is often phototherapy. How does that work?
The blue-green light changes the unconjugated bilirubin in the skin into a different form, lumirubin.
Which is water-soluble.
Exactly. So it can be excreted by the kidneys directly, bypassing the liver's conjugation step.
Nursing care involves
Maximum skin exposure, just a diaper. Covering their eyes to protect the retinas. Using a low-heat isolate. Monitoring temperature closely, ensuring lights are positioned correctly.
Can they come out for feeding?
Yep. Just remove the eye patches during feeds. Monitor fluid status. They can lose more fluid under lights, but routine supplementation isn't usually needed if hydration is okay. Watch for rebound levels after stopping.
Severe cases might need
Exchange transfusions in the NICU if phototherapy isn't enough.
Okay, moving down. Gastrointestinal system. Assess the abdomen.
Should look cylindrical. A sunken abdomen can signal distress. Their stomach is tiny at birth, maybe 30-60 milliliter capacity, but grows fast.
Enzymes are present.
For protein, moderate fats, simple sugars. The valve at the top of the stomach, the esophageal sphincter, is a bit weak initially.
Why they spit up easily.
Exactly. Improves over time.
And the school progression is unique. First, meconium.
Thick, black, terry, passed in the first 24-48 hours.
Then transitional stools.
Kind of changing color and consistency.
And finally, milk stools. Different for breastfed versus bottle-fed.
Yep. Golden, semi-formed for breastfed. Drier, pale yellow or greenish brown for bottle-fed. Loose green stool is diarrhea, a major cause of hospitalization in infants.
And stool changes again with solids.
Yeah, you might see undigested food pieces, that's normal.
Genitourinary system next. Kidneys mature around 34-36 weeks.
Functionally mature, yeah. They make urine in utero, but don't fully concentrate it until about 3 months old.
So expect lots of wet diapers.
6-10 a day is a good sign of hydration and kidney function.
Genitalia assessment. Males. Descended tests. Urethral opening center.
Right. If the opening is on the underside, hypospadias or top epispadias. Circumcision is delayed for surgical repair. Scrotum might be swollen initially.
Females. Labia majora covers minora.
Usually at term. Vaginal tags are common, normal. Ambiguous genitalia needs immediate investigation.
Pseudomenstruation.
Little white or blood-tinged mucus discharge from mom's hormones withdrawing, totally normal. Breast enlargement in both sexes at term is normal too.
Circumcision care, if chosen, involves pain management.
Absolutely. Acetaminophen an hour before, topical cream 60-90 minutes before, and sucrose water ordered med acts as an analgesic for younger infants.
Positioning.
On a circumcision board, upper body covered for warmth.
Post-procedure.
Petroleum gauze to the glands, don't remove it, let it fall off. Diaper loosely. Assess for bleeding every 4 hours first day. Watch for infection signs. Ensure voiding within 24 hours.
Acetaminophen for pain at home.
PRN, yeah. And that yellowish eschar. Normal healing. Don't wipe it off.
The sources mention cultural context.
Religious reasons, higher incidence here versus elsewhere. AAPACOG classify it as elective.
Care for uncircumcised males.
Teach parents not to force foreskin back. Clean meticulously. Don't insert objects.
Okay, skin system again. Assessing color requires good lighting.
Pink is normal. Pale dusky might be cardiac. Jaundice checked by fingertip pressure is helpful, but bilirubin level is gold standard.
Other normal findings. Lanugo.
Fine body hair, fades.
Acrocyanosis.
Bluish hands, feet. Normal first, 24-48 hours.
Melia.
White cysts, leave them alone.
Vernix.
Cheesy stuff, protective, leave increases. Amount indicates gestation.
Eriema toxicum.
Newborn rash, looks like flea bites, disappears.
Acne.
Around 1 month, little red pimples.
Mongolian spots.
Dark blue-black areas, often sacral, prominent in certain ethnicities. Document size location carefully can be mistaken for bruising. Fade by school age. Birthmarks, stork bites noted too.
Cord care after clamp off.
Keep it dry. Open to air often standard now. Diaper folded below cord. Dries, turns black, falls off in 2 weeks. Sponge baths until then.
Skin to skin is revisited here. Good for skincare, too.
Minimizes breakdown. Ahon Brief recommends it for stable-term infants, first hour, during procedures. Uninterrupted off, though.
Finally, immune system. Babies born into a non-sterile world.
Right. Immunity in utero was passive, relying on mom. IgG is the only antibody crossing the placenta.
Provides most antibodies at birth.
About 75–85%. Breast milk provides all 5 immunoglobulins, especially IgA for gut respiratory protection.
Active immunity making their own antibodies.
Starts around 2–3 months from exposure or vaccines. Fully developed around 6 months. Makes those first months vulnerable.
Food allergies, interesting point in the sources.
Yeah, no evidence delaying solids beyond 6 months prevents allergies. Recent research even suggests early introduction, 4 to 6 months, might help prevent some.
Infants higher risk for infection.
Immature immune response, fewer maternal antibodies initially, stress, skin breaks from procedures.
And microbiome seeding is fascinating. Vaginal versus C-section exposure.
Vaginal birth exposes to mom's vaginal gut flora. C-section babies miss this. Exposed to skin environmental bacteria may influence later immunometabolic health.
Seeding happens through vaginal birth, skin-to-skin, breastfeeding.
Yes. Research on vaginal swabbing for C-section babies is ongoing, but it seems complex, related to body site colonization too.
It's truly amazing to witness these tiny humans grow and learn at such speed. Let's shift focus to their incredible development, those built-in reflexes, how they explore.
Monitoring developmental milestones is absolutely crucial. These skills they acquire around certain ages, their timing tells us a lot about whether development is on track.
Part of assessing neurological maturity involves checking reflexes. Asymmetry is a big red flag, right?
Definitely.
Yeah.
Suggests a potential issue on one side. Key ones include the Moro, that startle reflex.
Arms fling out.
Yeah. Or the rooting reflex, touch their cheek. They turn to find food.
Sucking.
Sucking. Palmar grasp, grabbing your finger. Plantar reflex, toes curl. And stepping or dancing when held upright.
Each appears and disappears at typical ages.
Shows how the brain is maturing, those higher centers taking over.
Beyond reflexes, the Ballard Maturational Scoring Tool estimates gestational age.
Right. Looks at 6 neuromuscular signs, muscle tone, flexibility, and 6 physical signs, skin texture, lanugo, genitalia maturity.
Scores correlate to weeks.
Yep. Used with weight, length, head circumference to classify as AGA, SGA, LGA. Term babies score higher.
Speaking of size, growth parameters are key. Average weight.
Around 7.5 pounds, 2,500, 4,000 grams for term. SGA below 10th percentile, LGA above 90th. Low birth weight, 2,500 grams. Very low, 1,500 grams.
Height. Head circumference.
Average height, 20 inches. Head circumference usually about the same or 1 to 2 centimeters less than chest. Much smaller head, microcephaly, or significantly larger, maybe increased ICP is a concern.
There are predictable periods right after birth, too. First period of reactivity.
First 30 minutes to 2 hours. Might be wide awake right after birth, then get really sleepy, unresponsive, makes feeding tough sometimes.
Then the second period.
Hits 2 to 8 hours later. They wake up, become alert, responsive, heart respiratory rates pick up, muscle tone increases, often pass more stool. Great time to try feeding again.
We monitor developmental milestones throughout the first year, around 3 months.
Start sleeping longer stretches, primitive reflexes fade, show interest in spoons, develop binocular vision, drooling, chewing starts with teething.
By 6 months.
Usually sit when propped, support some weight standing, recognize familiar people objects, start babbling.
Things really take off between 6 and 9 months.
Oh yeah. Master rolling, sit unsupported by 8 months usually. Transfer objects hand to hand, point, develop that fine pincer grasp around 9 months.
Exploring everything.
Putting feet in mouth, pat a cake, mirror play, start understanding animate versus inanimate, often develop stranger anxiety.
Object permanence emerges.
Knowing something's there even if hidden. Vocalizations get more complex. Around 9 months, might hear specific data and mama, understand, bye-bye, no.
Pulling to stand. Crawling.
Pulls to stand 8–9 months. Pincer grasp 8–9 months. Crawling sometimes backward first. Responds to name 8–9 months. Practice grasp release. Look for dropped toys. Test responses. Vision improves. Express more emotions.
9 to 12 months.
Security objects might appear. Love board books. Understand simple directions. Maybe say 2–3 words besides dada mama. Legs might still look bowed. Feet turn in normal.
And 12 months is the transition to whole cow's milk.
Whole milk. Need that fat content for brain development. No 1% or 2% yet.
Sensory development is rapid. Vision least developed at birth.
Yeah. Prefer high contrast, see clearly only short distance. Poor peripheral vision improves.
Smell is well developed, though.
Recognizes mom's scent. Sources mention research on soothing odors, amniotic fluid, colostrum, breast milk, help locate nipple, reinforce connection.
Hearing functional at birth, screened with ABR or OAE.
Non-invasive tests, often while sleeping. Ear exam on infant. Pull pinnae straight back and down.
Communication styles adapt.
Higher pitches get attention. Deaf mothers often use slower, deliberate sign. Touch is incredibly important. Connection, comfort, pain management.
Language acquisition mix of innate and learned.
Seems like it. Progresses from cries to coos, babbling, mimicking sounds, single words, vocabulary explodes. Interaction is key.
Cognitive development in the first year is explosive.
Processing info, memory, problem solving. Primitive reflexes fading shows higher brain centers taking over. Assessment tools like Brazelton MBAS, newborns, DeSalle, Denver, Bailey scales track progress, identify delays.
Psychosocially, Erickson's trust versus mistrust in the first year.
Critical stage. Building trust needs consistent comfort, predictable responses, minimal fear. Establishes lifelong expectation of a safe world. Mistrust develops otherwise.
And play is how infants learn. Sensory motor focus.
Toy safety number 1. Big, no small detachable parts. Simple toys best for short attention spans. Unbreakable mirrors, rattles, soft stuffed animals, sewn features, large snap toys, musical toys.
Supervised tummy time essential.
Builds neck-shoulder muscles. Use soothing voices, facial expressions, music. Engage them when alert. Watch out for sibling toys with small parts. Mirror play, often a hit. Play is vital even for hospitalized infants, fosters attachment development.
Moving on to some really practical essentials. Feeding these tiny humans and making sure they get that crucial sleep.
Absolutely. Nutrition and sleep choices. The routines established in the first year. Profound impact. And safe sleep is non-negotiable.
Feeding before 6 months. Breast milk or formula. WHO recommends exclusive breastfeeding first 6 months, continued to 2 years.
Healthy People 2030 goals aim to increase rates, but the decision is so personal, depends on knowledge, experience, culture, support, career. Many factors.
Zika virus and breastfeeding.
CDC WHO say benefits outweigh theoretical risks. Transmission via breast milk isn't confirmed. Risk is mainly congenital exposure. After 6 months, calorie needs are highest, need protein, fat, carbs.
Non-nutritive sucking pacifiers, fingers.
Natural self-soothing, important for neurodevelopment, different mouth movement than nursing. Wait on pacifiers if breastfeeding until established. Never tie or clip to clothing, strangulation risk. Limit use as they get older.
Breastfeeding. Optimal method. Provides everything.
Start within the first hour, ideally. Benefits for moms, decreased cancer risk, faster uterine recovery, weight loss, bone density, bonding.
Benefits for babies, huge. Immunity boost, fewer infections.
Better GI maturation, decreased risk of type 1 diabetes, childhood obesity, better jaw development, some cancer protection.
Composition changes.
Mostly water, plus fat, carbs, lactose, protein, weight-casein ratio adjusts, antibodies, enzymes, growth factors. Colostrum first milk, high protein antibodies, lower fat carb, helps pass meconium.
Milk production. Supply and demand.
Prolactin drives production. Infant demand, woman supply. Oxytocin triggers letdown reflex.
Triggered by baby crying. Thinking of baby.
Yep. But stress, anxiety, pain can inhibit it. Learning feeding cues is important early. Rooting, stirring versus late. Crying makes latch harder.
Latching. Getting a good mouthful.
Not just nipple. Hold breast like sandwich. Stimulate rooting. Get nipple far back when mouth wide open. Nose, cheeks, chin touch breast. LATCH score helps evaluate.
Successful feeds 10-30 minutes.
Usually. Shorter might be poor position sleepy, much longer might be non-nutritive. Break suction with finger. Good weight gain. 12 to 1 ons day is key sign.
Expressed milk storage.
Room temp 4 errors. Fridge 5-7 days. Deep freezer 6-12 month. Thaw in fridge warm water, never microwave. AAP recommends breastfeeding first year minimum. Lactation consultants, IBCLCs, invaluable.
Weaning ideally gradual.
Eliminate 1 feed at a time, usually daytime first, nighttime last.
Bottle feeding, valid choice.
No guilt. Formula or express milk. Commercial formula is nutritionally complete. Preparation is key. Follow directions. Powdered, not sterile. Teach hygiene, prep, sterilization. Warm gently, no microwave. Always hold baby bonding time. Never prop bottle choking your infection risk. Burp frequently.
Advancing feeding after 6 months. Solids. Readiness signs.
Around 6 months. Sit alone supported, good head control, draws in lips, keeps food in mouth. Extrusion reflex gone. GI matured.
Introduce some spoon, not bottle. Iron fortified rice cereal often first.
Historically, yeah, lower allergy risk cited. Introduce 1 single ingredient food at a time. Wait 2-3 days watching for reactions, rash, diarrhea, etc. No added sugar sweeteners, corn syrup.
Self-feeding starts when?
When they can get food to mouth. Soft, mashed table food. Cut very small, choking prevention. Cooked pasta, cheese, soft fruits, veggies. First teeth bite, don't grind. Wean from bottle to cup 1 year.
No cow's milk before 12 months.
Low iron, risk of anemia. And no honey or corn syrup before age 1, botulism risk.
Sleep patterns change dramatically. Newborns sleep a lot but fragmented.
Right. 8-9 hours day, 8 years night initially. Sleeping through night often starts 3 months as stomach grows. By 6 months, more adult-like REM non-REM cycles. Lots of REM early for brain growth. Sleep tied to growth spurts.
Safe sleep practice is paramount. Reduced FY in 12 months, peaks.
2 to 4 months. Risk factors. Male, winter, certain races, no prenatal care, maternal smoking.
Safe to sleep campaign key message.
Always sleep on their backs. Every nap, every night. Side sleeping unsafe. No wedge positioners. Skin to skin good, but return to owned safe sleep surface.
Avoid overheating.
No head covering, don't overbundle. Signs. Sweating, damp hair, flushed cheeks, heat rash, rapid breathing, dress lightly, 1 layer more than adult, sleeveless sleep sack, okay.
Safe sleep surface.
Safety approved Crevassin play yard. Fern mattress, fitted sheet, JPMA certified, slats equals 2 38 inches apart. Never on adult beds, sofas, soft surfaces.
And the big one, nothing else in the crib.
No toys, soft bedding, blankets, pillows, stuffed animals, bumper pads, suffocation entrapment hazards. AAP, very clear, no bumpers.
The low-free area vital. Breastfeeding protective, pacifier used at bedtime protective.
Yes, linked to reduced risk. No attachment cord. Keep immunizations up to date. Bedside sleepers need CPSC standards. Baby boxes temporary, need more research. Common culturally, but AAP advises against due to risks. Room sharing, baby in own space in parents' room, safer alternative. Infant sleep biological, but heavily influenced by environment parents. Bedtime routines beneficial. Recommended sleep 4-12 Mo. 12, 16 8ers, total 24 8ers.
Brief resolved unexplained events. BRU.
Formerly Altanir Missits. Scary episode. Color change, apnea, tone change, choking, witnessed in infant 1R, cause unknown, risks, TUMO, preemie, prior events. Evaluation involves observation, maybe ECG, labs, pulse ox.
Wrapping things up, let's talk practicalities. Essential nursing care, keeping them safe, supporting families.
Yeah, taking all this knowledge and applying it effectively, both in care and teaching parents.
Medication administration. Children are not little adults. Dosing precise, weight-based.
Use syringes for liquids. Aim towards side back of mouth. Generally don't re-administer if spit vomit immediately. No household spoons.
Neonatal considerations.
Lower stomach acid affects absorption. Dosing tricky, weight BSA, risk for toxic levels, immature liver kidneys, smaller pancreatic enzymes, immature kidney function affects excretion.
For older infants.
Slow approach, eye level, gentle handling, caregiver lap, distraction, no meds in full bottle, hold in nursing position, let's swallow between squirts, don't lay flat right after. Always check with practitioner before OTC meds.
Knuckle meds.
Lubricate, insert 12-inch, hold buttocks 10 minutes. IM injections in vastus lateralis. Needle size volume varies. Infants usually 1-inch needle, max 1L.
Pain management. Infants feel pain like adults.
Assess based on behavioral physiological responses. Repeated pain exposure can increase response over time.
Pain scales help.
J-ups, NIP teams, Fleffy, Riley, PIPP, cry is mentioned. Fleff LACC is face, legs, activity, cry, consolability. Score 0-10. Helps quantify pain.
Non-pharmacological pain prevention management.
Breastfeeding and non-nutritive sucking, kangaroo care, swaddling, limiting stimuli, attention to cues. Prioritize these.
Colic. Intense crying, often lute day. Diagnosis of exclusion.
Right. Rule out other causes first. Parent education, burping, no formula change without MD. Okay, breastfed mom might try diet changes, less spicy, gassy dairy corn. Comfort measures, swaddle motion. Crucially, parent support and breaks.
Health promotion. Teaching infant care skills.
Heating, bathing, skincare, diapering, home infection control, hand washing, #1. Limit sick visitors. Ensure household immunizations up to date. Flu, pertussis, COVID.
Positive parenting practices.
Talk to baby, respond to sounds, read, sing, praise, cuddle, play when alert, infant-child CPR, vital skill.
Pediatric medical home model.
AAP model, accessible, continuous, comprehensive, family-centered, coordinated, compassionate, culturally effective primary care, coordinates across system.
Umbilical cord blood banking revisited.
Fee-for-service storage. Harvesting prevents delayed cord clamping. Need to counsel parents on this trade-off.
Immunizations critical. Discuss benefits risks clearly.
Adult behavior influences child rates. Hep B within 24 H'ers now. DTaP not before 2 Mo.
Signs of illness parents should know.
Fever, 99.3 F, axillary 100.3 F, rectal. Vomiting, 6 wet diapers day, sunken bulging fontanelles, loss of appetite, foul odor bleeding from cord circumcision, decreased eloclethargy, increased irritability, blue cool hands feet, rash, excessive drooling, not teething, refusal to lie down, 8 Mo's.
Milestone concerns red flags.
No head lift attempts prone, no improvement head control, no response loud noises, extreme floppiness, lack of response sense visual cues, inability focus on caregiver eyes, poor weight gain, not crawling by 12 months, seek help.
Emergency care education for parents.
Stay calm, rescue breathing, call 911, pressure for bleeding, seizure care, lower side, nothing in mouth. Don't move if serious injury unless unsafe. Stay with infant, bring meds poisons, provide history.
Hospitalized infant challenges.
Rapid growth EV period disrupted. Aware of parent absence, 6 Mo, sense parent anxiety. Nurse cares for infant A&E family. Pain management key.
Chronic care situations, prematurity.
Primary low BW cause. High-risk dev motor delay. Ballard score equals 37 low B case. Need multidisciplinary team. RSV, common respiratory virus, risky for young pre-emesis conditions.
Other conditions needing chronic care.
Metabolic genetic disorders. Zika virus birth defects if infected during pregnancy, no vaccine. Group beta strep, GBS, screen moms, 35-37 WKs. Treat in labor if positive. HIV diagnosis, antiretroviral therapy, important.
Finally, safety measures paramount. Accidents leading cause of death, 19.
Caregiver responsibility for safe environment. Anticipatory guidance. Appointments, vaccines. Safe to sleep. Crib safety, JPMA slats, equals 238 instance. Diaper rash prevention, emergency numbers handy. Child-proof locks, gates, window guards, hand washing. Limit sick visitors, smoke-free, firearms locked. Never leave child alone in car.
Limiting submersion.
Infant swim classes risk water intoxication. Coli, limit pool time.
Burn prevention critical.
No holding baby with hot liquids cooking, no microwave formula milk. Sun safety, 6 Mo sunscreen hats. Pot handles turned in, check bathwater temp. Lower water heater, 120F 48.8C. Cord outlet secured. Flame retardant sleepwear.
And cultural competence revisited.
Discuss practices like circumcision co-bedding factually, non-judgmentally, while prioritizing evidence-based safety, essential support.
Wow, that was a ton of essential info packed into one deep dive. From those first crucial seconds and system transitions.
Yeah, mastering APGARs and breathing.
To navigating those rapid milestones, understanding unique needs for nutrition and sleep.
Right, safe sleep. Feeding choices.
And providing us essential nursing care and safety education there is just so much to caring for tiny humans.
And understanding these fundamental concepts like, the significance of that APGAR score, how quickly their bodies adapt, the purpose of reflexes, the science behind safe sleep, or the nuances of metabolism and pain. It doesn't just help us provide better care, it also deepens our appreciation for the incredible complexity of this period.
So true. Okay, final thought? Considering the source highlights the incredibly dynamic and interconnected nature of infant development, how all these systems and milestones are rapidly integrating in that first year.
Yeah, it all happens so fast.
Take a moment to ponder this. How does this intense period emphasize the profound and lasting impact that consistent, informed, and compassionate caregiving truly has on a human life?
Snuggle the facts. See you in the next one.